For the past decade or so, we've only had one drug for liver cancer, and that's been sorafenib. I would say there's still significant unmet needs in the frontline setting. We want to improve on this 10-month median survival. To date, we've tried several times, but I think it is possible if we have the right drug and the right patient population. With the approval of regorafenib in second line, that's a huge step forward. Again, giving patients and doctors options. But again, I think there's still room for improvement. Hopefully some of the ongoing studies will clarify that. We still have a large group of patients who have intermediate stage liver cancer that do eventually progress to advanced disease. And if we could figure out a drug in a population of patients with intermediate disease that could work in cooperation with chemoembolization or adjuvant to chemoembolization or some sequence that would show to improve survival, that would be great. It's a difficult population to study. And even in patients who are potentially cured with RFA or with surgery, since the recurrence rate is very high, to get an effective drug in the adjuvant setting would be a true advance. So there's still a lot of work to be done, and hopefully as we see more agents that are active in the advanced setting, we'll figure out how to use them in earlier stage disease, as well as novel combinations in the frontline setting. I think a lot of us are excited to see that happen too.
How does the future for patients with HCC look like? This is, I think, a very good and important question. If you look back, we had a couple of treatment options available, which we use now for more than 10, 15 years, and there was not significant change. We had a couple of trials, many of them failed, and the treatment option did not really improve. Now we have the first clinical trial in second line with significant improvement of overall survival. We have some interesting drugs like ramucirumab and tivantinib that could work in specific subgroups. And with the checkpoint inhibitors, we have another group of drugs that appear to also be effective in HCC. Not in all patients, but in subgroup of patients. And I think this is the future of HCC. We most likely will not have one drug that fits all patients. Even with regorafenib, which has been positive in the resource study, we have a subgroup of patients that are tolerant to sorafenib, not all comers. And therefore, I think in the future, first of all, the treatment might get more individualized so that we have specific clinical, maybe molecular markers on which we decide on our treatment. And the other point would be, so far we were not really successful to combine systemic therapy with local therapies. So this is something with the new drugs, specifically with the checkpoint inhibitors, that we have here a way to combine local therapies and systemic therapy. I think this is very interesting. And the third point is, and we have mentioned this before, when should we switch from local therapies to systemic therapies with all, I mean, at the moment we only have 2 drugs available, if you are honest, but we have a lot of clinical trials. And this brings really the question more into the focus, when should we stop local therapies? Specifically, if we think about studies like the bridge studies, which highlighted that TACE, for example, is most often used, the most often used first-line treatment for patients with HCC. We do not have really clear data when to stop TACE. And with now these more successful clinical trials, more treatment options available, and most likely approved in most countries, these are really the important points to consider.